Chapter 17, we are talking about how we work with vulnerable populations with access and functional needs for emergency planning. So disasters, whether or not they're natural or man-made, don't affect everybody equally. A significant portion of the population has access and functional needs that require additional support before, during, and after emergencies. FEMA defines access and functional needs broadly. It includes anyone who may need assistance due to temporary or permanent conditions that limit their ability to act independently. Importantly, no formal diagnosis is required. This can include individuals with disabilities, older adults, children, pregnant women, people with limited English proficiency, and those experiencing homelessness, as well as individuals with chronic conditions and people without reliable transportation. In fact, when you consider children, seniors, non-institutionalized persons with disabilities, and individuals with limited English proficiency alone, that group may represent roughly half the population. When we add poverty, geographic isolation, medical dependency, that scope becomes even larger. Planning for access and functional needs is not a niche concern. It is central, and it is central to equitable and effective emergency preparedness. The World Health Organization conceptualizes disability in three broad categories. The first one is impairment, meaning a loss or abnormality in body structure or function, including mental functioning. Second is activity limitation, such as difficulty walking, seeing, hearing, or problem solving. The third one is participation restriction, which refers to barriers that limit involvement in daily life, working, self-care, recreation, or accessing health services. The CDC estimates that 61 million adults in the United States, about one out of every four, live with a disability. Globally, that number exceeds 1 billion people, or roughly 15% of the world's population. The American Community Survey further classifies disabilities across domains like hearing, vision, mobility, cognition, self-care, and independent living. Disability often intersects with other chronic conditions like diabetes, kidney disease, as well as across the life course. Nearly anyone may experience temporary or permanent disability. Disability is common, multidimensional, and central to inclusive public health planning, not peripheral. The Americans with Disabilities Act was signed into law in 1990 by President George H.W. Bush and fundamentally changed access and equity in the United States. It prohibits discrimination against individuals with disabilities across housing, employment, education, transportation, and public life more broadly. It also requires reasonable accommodations so individuals with disabilities can access opportunities and perform effectively in the workplace. In public health emergency planning, the ADA is not optional, it must guide strategy. Reasonable accommodation should be built into preparedness plans from the beginning, not added as an afterthought. Individuals with disabilities should have access to the same emergency preparedness programs, trainings, communication systems, and services as everyone else, appropriately modified to meet specific needs. Some states maintain disability registries to help responders locate and assist individuals during emergencies. However, registries have their limitations. Not everyone enrolls, the information may be outdated, and some individuals may be reluctant to share personal data. Therefore, registry should be viewed as one tool within a broader inclusive planning strategy, not a complete solution. At its core, ADA informed emergency planning is about equity, access, and ensuring no population is overlooked during a crisis. Effective emergency planning begins with knowing your community. How many individuals may have disabilities, where they live, whether they have caregivers, and what specific supports that they might need. That information directly translates into saved lives. Planning must go beyond identification. It requires evacuation plans with accessible transportation, contingency plans to maintain medical services, communication strategies for individuals who are deaf or blind, and appropriate equipment, medications available at shelters. Community-based organizations and disability advocates should be actively involved in exercises, tabletop simulations, and communication planning, not consulted after the fact. FEMA guidance emphasizes integrating functional needs and support services into shelters. That includes accessible communication, personal care, and hygiene accommodations, as well as dietary considerations, accessible restrooms, support animals, wheelchair access, adequate staffing, specialized equipment, medications, transportation planning, and post-disaster transition back into the community. The key message is this: inclusive planning is not an add-on, it must be embedded in every phase of preparedness response as well as recovery. Chronic diseases are conditions that last a year or more and require ongoing medical treatment or limit daily activities. In the United States, 6 in 10 adults live with at least one chronic disease, and 4 in 10 have two or more. Nearly half of the population reported using at least one prescription medication in a 30-day period. And among adults over 60, that number rises to 85%. These statistics have major implications for emergency preparedness. During disasters, access to pharmacies may be disrupted. The CDC recommends that individuals maintain an emergency supply of essential medications whenever possible. Public messaging should reinforce this preparedness step. But at the same time, states have emergency prescription refill laws that allow pharmacies to dispense certain critical medications during declared emergencies. Emergency planners must understand that their state's legal framework and develop systems to ensure continuity of care for individuals with chronic conditions, whether those whether those people are in shelters, evacuation centers, or during prolonged disruptions. Chronic disease management is a central component of disaster resilience. Dialysis is a powerful example of how chronic disease intersects with emergency preparedness. As rates of obesity, diabetes, hypertension have all increased in the United States, kidney disease has arisen alongside them. Today, nearly 800,000 Americans live with end-stage renal disease, and the majority depend on dialysis to survive. Dialysis isn't optional. It's required multiple times per week. That means patients rely on functioning clinics, electricity, clean water, transportation, medications, and trained staff. When disasters disrupt infrastructure, whether it's a hurricane, a wildfire, pandemic, or power outage, dialysis patients quickly become one of the most medically vulnerable populations. This is why preparedness planning for dialysis cannot be an afterthought. Organizations like the National Kidney Foundation provide guidance for both patients and planners, helping individuals prepare emergency contact plans, and anticipate service disruptions. The Kidney Community Emergency Response Coalition, operated under CMS, provides training and coordination to support dialysis networks nationwide. Their goal is simple: to save lives and reduce complications during disasters. Protecting medically dependent populations requires coordination, infrastructure, continuity, and advanced planning. When we talk about public health emergency powers and preparedness together, dialysis patients remind us that emergencies don't just affect those who are healthy. They can become immediately life threatening for those already living with chronic diseases. The aging of America has major implications for emergency preparedness as well. Since 2010, the population at age 65 and over has grown significantly as baby boomers enter senior citizenship. Today, more than 54 million Americans, about 1 in 6, are 65 or older. Many of them live with chronic disease, disabilities, poverty, or in rural areas where access to services may already be limited. From a preparedness standpoint, older adults are more medically vulnerable and are often more socially isolated. That means that they may not receive or act on emergency messaging in the same way as other groups. Effective planning must intentionally include seniors through outreach in community groups, assisted living facilities, nursing homes, houses of worship, and caregiver networks. Organizations like the American Red Cross and the AARP provide tools to help communities tailor preparedness efforts specifically to older adults. As the population ages, emergency planning must evolve to meet the needs of an increasingly older and medically complex society. In this visual, population pyramid shows the difference between 1960 and projected 2060, where we have the male and female populations between those 100-year spans, with a big bulk of the population shifting towards those older age brackets. And this chart as well just shows the percent of population in those older age groups, 60 to 75 and over. Catastrophic weather events reveal serious gaps in how we protect people with disabilities. Hurricanes Katrina and Rita in 2005 made it clear that evacuation systems, shelters, and communication strategies were not designed with many disabled individuals in mind. Deaf and blind residents struggled to receive evacuation information. Shelters lacked accommodations for wheelchairs and service animals, and a disproportionate number of fatalities occurred among people with disabilities. In response, advocates developed a function-based planning model known as CMIST, focusing on communication, medical needs, independence, supervision, and transportation. Rather than labeling people as special needs, CMIST asks a practical question: what functional support does this person require to survive and remain safe during an emergency? This framework has been adopted by FEMA, ASPR, and NATO because it aligns with the whole community approach. Effective emergency planning isn't about categories, it's about ensuring that every functional need is anticipated and addressed before disaster strikes. Emergency planning has historically been male dominated, and as a result, the needs of women, infants, and children have often been under considered in disaster response. While women are resilient and capable, disasters create gender specific challenges that are complex and frequently under researched. The problems experienced by women and dependent children during emergencies are often inadequately addressed. And at the same time, the social and economic position of women in the United States has shifted dramatically over the past 50 years. Women now make up nearly half of the workforce, and over three-quarters of unmarried mothers are employed. Yet women, especially Black and Hispanic women, are more likely to be among the working poor and more likely to hold minimum wage jobs. Importantly, women are disproportionately shouldering caregiving responsibilities for children and elderly family members. Disaster planning must account for gendered economic realities and caregiving roles. Ignoring these structural factors increases vulnerability during emergencies. After Hurricanes Katrina and Rita, we saw prenatal care disrupted, premature infants separated from mothers, and women in shelters exposed to sexual assault, with limited access to emergency contraception. These events underscore that women have specific and often overlooked needs during emergencies. Disasters also disrupt women's economic stability. During the early months of COVID-19, women accounted for more than half of total job losses, particularly in service sectors like hospitality, childcare, and education. When schools and child care centers were closed, caregiving responsibilities intensified, creating further barriers to employment. Because women often serve as caregivers, breadwinners, and social anchors within families and communities, excluding them from emergency planning weakens the entire response. Preparedness must incorporate gender-aware planning and include women leaders in decision-making to ensure that a true whole community approach is taken. Children's lived experiences in the United States have changed dramatically over the past several decades, and those shifts matter for disaster planning. Today, 73 million children, about 22% of the population, are under 18. 40% of births are to unmarried women, and roughly one-third of children live in single-parent households. More than 10 million children live in poverty, and an estimated 1.5 million public school students experience homelessness in a single school year. These social conditions increase vulnerability even before disaster strikes. We also see troubling rates of victimization. 2019, more than 650,000 cases of child abuse and neglect were reported nationwide. The first year of life is the most dangerous, and neglect accounts for the majority of cases. Girls experience slightly higher rates of victimization than boys, and hundreds of children are identified as victims of sex trafficking every year. Disasters do not create vulnerability, they amplify existing social and economic fragilities. Effective preparedness must account for poverty, housing instability, and child protection risks long before an emergency happens. Beyond poverty and abuse, many children today are shaped by another dynamic, which is being managed to accommodate adult priorities. Even in middle class and dual income households, children often navigate stress from busy schedules, shifting family structures, and limited adult time. That management may look like heavy screen exposure, overscheduling, or even medication for behavioral control. At the same time, public health data show troubling trends: high fast food consumption, rising rates of childhood obesity, insufficient sleep, and over 5 million children living with asthma. All of this matters in emergencies. Planners must understand the modern context of childhood. Simply planning for reunification with caregivers is not enough. Emergency leaders need to be aware of social, medical, and psychological vulnerabilities that children may bring into shelters and disaster settings. They cannot solve every structural problem, But recognizing warning signs and knowing when an intervention is needed can prevent harm and, in some cases, save a child's life. When we discuss public health emergency planning, it's critical that we recognize the unique status of American Indian and Alaska Native communities. These communities descend from highly sophisticated pre-Columbian civilizations and today comprise 574 federally recognized tribes across 35 states, representing about 2% of the U.S. population. Tribes hold a distinctive political status as sovereign nations within the United States. This means that American Indian Alaskan Native individuals are citizens of three sovereigns: their tribe, the state which they reside, and the federal government. That layered governance structure can complicate disaster response and recovery. In addition, many tribal communities experience higher rates of poverty, health disparities, rural isolation, and limited broadband or internet access, factors that can intensify vulnerability during emergencies. For emergency planners, this means that inclusion is not optional. Tribal representatives must be engaged in preparedness and planning exercises, included in communication channels, coordinated with tribal leadership to ensure timely, life-saving information reaches those communities. Rugged individualism is a deeply rooted value in American social, economic, political life. It emphasizes autonomy, self-reliance, and the belief that success is primarily the result of individual effort and personal choices. However, this emphasis on personal freedom can sometimes hinder collective action, especially in public health. As we saw during COVID-19, resistance to mask mandates, social distancing, and vaccine uptake were significant. Vaccine hesitancy, in particular, reflected not only misinformation and mistrust, but also a cultural belief in the right to refuse interventions, even when they protect the broader community. This ideology is also reflected in the American dream narratives and employment structures that assume people can function nearly 100% of the time with minimal social supports. Yet over the past 4 decades, economic mobility has declined, wealth inequality has widened, and health outcomes have gotten worse. For public health emergency planning, understanding the cultural framework is critical because preparedness strategies must operate within and sometimes counterbalance deeply held beliefs about freedom and responsibility. Although the United States is one of the wealthiest countries in the world, it performs poorly on many key quality of life and health measures compared to other high income nations. We spend nearly twice as much on healthcare, yet we have lower life expectancy, higher suicide rates, higher chronic disease burden, and roughly double the obesity rate of our peer countries. Work policies also play a role. U.S. workers often work longer hours with fewer benefits, including limited paid leave, minimal paid holidays, and no universal health coverage. In fact, the U.S. remains the only Western nation without guaranteed health coverage for all its citizens. These structural realities are often defended through the lens of that rugged individualism. The COVID-19 pandemic exposed these weaknesses. Workers without sick leave or health insurance, many in essential in-person jobs, face disproportionate risk. Ultimately, health and quality of life outcomes in the US are not evenly distributed, and emergency preparedness must account for these structural inequities if we aim to protect entire communities. Public health does not operate in a vacuum. It operates within a social status hierarchy. People with access and functional needs are often more likely to be poor, marginalized, and socially isolated. Over decades of research, we've learned that health outcomes are shaped by social and economic systems that position individuals differently within that hierarchy. One classic illustration of the social gradient is health is the Titanic. First class passengers survived at higher rates than second class passengers, and second class more than third. Closer to our time, hurricanes Katrina and Rita showed similar patterns. Those who suffered the most illness, death, and displacement were disproportionately poor and from minority communities. These patterns reflect the social determinants of health, the conditions in which people are born, live, work, and age. These conditions shape exposure to risk and access to protection. Preparedness must intentionally pursue health equity, ensuring that everyone, regardless of social status or functional needs, has an equal opportunity to be protected in disasters.